So thanks again for having me, and I'll give you a short overview on my experience with radiolucent implants and spine tumors. We have a very busy spinal oncology practice, and you see the numbers here. And we had that published, what we did on metastasis primary tumors. And what we found out that one of the main problems was that in order to reduce wound problems, we were establishing a concept of being minimally invasive, and for that, using navigation in all of those cases. And plus, we basically never aimed to have fusion, so we were very liberal in having cement augmented screws. And about almost 7-8 years ago, we added as a default radiolucent implants for those patients, be it secondary or primary tumors, because of better follow-up imaging and radiation therapy. And I will elaborate on that. This is taken out of the large series, which is now published in Cancer. It's an open access journal, so you can look at that. It summarizes what I will give you later on. And also the vertebral body replacement, that means the anterior reconstruction with CFRP material and the cement augmented variation thereof. So it's a composite of PEEK and carbon, and the major advantage is, as you see on the right-hand side, on that CT, that has less artifacts on post-op imaging. So actually, you should have a better perioperative complication management, because if you have a problem, you can see you should have a better oncological follow-up, which is obvious in primary tumors, but it's getting more and more relevant also for secondary tumors. And plus, this is probably, it's a bit out of my expertise, but we're working in close collaboration with other radiation oncologists. And it has the main advantage in better radiation planning and execution. I will show you the principle of that at the end of my talk. And this is not only true for primary, but also for secondary tumors, which many people doubt. So this is what we use. It's a cannulated or fenestrated carbon PEEK pedicle screw. You can use it very much as cement augmentation. It has a titanium coated screw shank, and the only thing that is metal is a tulip. And then you have a tantalum mark and a screw tip, so you can see, even if you don't use navigation, what the screw tip is. The rods are PEEK carbon composite, and they are pre-bent. And then on the left-hand corner, you see the CFP distractable cage. If you have a very long construct and you have a lot of, or you have more deformity than these pre-bent rods can take, you can alternatively also use regular titanium rods, which come with the system usually. So our first experience was summarized in World Neurosurgery a couple of years ago by Florian Wengel, the first 30 patients, and what we learned from our initial experience here. So the first thing that we learned is if you want to see something with these radiolucent implants, it needs to be contrast enhanced and artifact reduced 1.5 Tesla MR. You see the difference. The same patient who came in with an incomplete spinal cord injury for recurrent metastasis, and he was instrumented with this with the system, but on the 3 Tesla, you don't see anything at all, as opposed to the 1.5 Tesla. So this is due to the metal tulips that still have a lot of artifacts. But obviously, from engineering reason, you can't change that. So our default case would look like that. This is metastasis in the upper thoracic spine. And what we usually do with those patients, we do posterior pedicle cementation and then flip the patient around either in the same stage or another stage and do a minimally invasive anterior reconstruction. And whatever you might call that, if that is separation surgery, not, I don't see a lot of difference between just putting a cage in or taking part of the tumor out that is close to the epidural space. And that's the way it looks afterwards on a plain X-ray or a CT scan. So a couple of things that needs to be taken into account. So these rods are not equivalent to your regular titanium alloy that you use with a 6.5 millimeter diameter. They have roughly the equivalent strength to 5.5 titanium alloy, which I will show you an example plays a role in several instances. So this is a hemangioma that was aggressively growing. So patient had a tumor corporectomy and only one below, one above construct. And that was on the thoracolumbar junction. It was a heavyset male. So in the 3 months, you see that there is subsidence of the cage, and not because the screws were broken, the screws were loose, or the rods were broken, but these rods are bending. So we tend to have at least 2 above, 2 below, sometimes even 3 above, 3 below, depending on the patient. So that needs to be taken into account. Later on, these were also available as fenestrated screws. You can see that even if you use fenestrated screws and with cement augmentation in that 1.5 Tesla on the right-hand side, there is not a lot of artifact, and you can still appreciate the site very well. Regarding safety efficacy, these screws are equivalent to any other fenestrated screws where you can have cement augmentation, same ratio of cement extrusion, etc., etc. So not a big difference here. Since we have started a number of years ago, also total navigation in the sense that we do anterior surgery, also navigated. Obviously, we were interested in how these cages perform, and this is now very recently out, the first 20 patients that we treated with distractible carbon peak cages. These are pictures taken from the publication. You can see what they look like. They're actually very feasible instrument to do that, and you don't have any more artifacts. You can see the T2 image sagittal and actual in the middle of that publication. Otherwise, nothing that is different from a titanium distractable cage. So this is the last series I was talking about, summarizing basically all our patients until, I think, 2021. A total of 321 patients were treated with primary and secondary tumors. More obviously secondary tumor, 306 had metastasis, and the other says 15 primary bone tumors that not a lot of difference. 25% were cement augmentated, and 40% almost had an anterior reconstruction in addition to that. So the safety issues, is there a specific problem related to that type of material? So the total complication rate was 17%. You see that there was only 1 pedicle screw breakage, 1 rod breakage, and pedicle screw loosening rate, of which is very well comparable. And the other things are not specific to the instrumentation. So the fear that this material has a higher incidence of screw loosening or breakage is not true, but you have to be careful if you use it, for example, in a prostate cancer patient who has a mix of osteoblastic and osteoclastic metastasis, and you try to screw it into an osteoblastic vertebral body, then you might shear off the screw, because the haptics are different than your usual titanium alloy, and you don't feel the resistance as you are used to. So now I show you that the advantages that we hypothesized are actually true. So this is a recurrent tumor of metastasis coming back, I think, with 1.5 years. That was, I think, a malignant melanoma metastasis. And he had another spinal cord compression, which was symptomatic, and you can very well see around the cage the recurrent tumor, and you know what to do. This is about perioperative complication management. Patient with a recurrent renal cell carcinoma metastasis, thoracic lumbar junction. I think you can see it here on the CT. And so we had radiotherapy before that, and the initial surgery was more than 3 years ago. So we indicated revision surgery because they said there is no option for further radiotherapy because they had a very high initial local dose. So we said that preoperative embolization should be performed, which was done in the same setting. We took tumor out, patient woke up and was bleaching. So immediately post-op, we did an artifact reduced 1.5 Tesla MR, which you see on the left-hand side. I think you can see very well that it rules out any other complication than what it was. That was a spinal cord ischemia due to the fact that the anterior spinal artery was embolized. So it rules out quite obviously not only an epidural hematoma as such, but if you look closely on the right-hand side in the image, the actual CT, you can see that. And I don't know if I have the picture farther down the line, you can also appreciate that he had a spinal cord ischemia 3 months down the line, the typical picture of that. That's another example which leads to the fact that I alluded to, that these implants also allow you to have, or allow you, the radiation oncologist, to be, let's say, more courageous with their recurrent or re-irradiation concept. This is the third recurrence of chordoma of the cervicothoracic junction. Always treated outside, came to us, actually was referred to our radiation oncologist because of the recurrence, and they were asked if they would do a third course of radiotherapy. And they said no, they wouldn't unless we would take out the tumor, which we did. You see the cage and the rods are in place. You can see that on the right-hand side in the MR that the tumor is completely out. The spinal cord actually is very, very well visible. And according to that, they could plan their dose and their fields accurately and did a third course of radiotherapy. This is now more than 3 years down the line, so the patient is still alive without recurrence. So it obviously seems to make a difference, and he has no side effects of the third radiation course. Same here, typical huge sacral chordoma, in which we do that construct and fixing on the pelvis or S2 ilioalar, and then do an en-bloc resection anterior posteriorly. It's quite obvious that in these cases, that type of material is superior for follow-up than anything else. So it's quite clear for proton beam, but so in my last slides, it is also had probably the other case showed you that it also has advantages in regular metastasis if you do re-irradiation, but also in the primary setting. So the conventional way to do radiation oncologists do the radiation is a 3 gray 30 fractions on the vertebral body plus, and that is taken from the Pachel landmark trial, all instrumented levels. They do that, I didn't know that, because they're unsure where to go, they can't see well. So if you do that now with radiolucent implants, you have less artifacts, so you can have a smaller volume and increase the dose. So you have a possible dose escalation and still have less risk to the spinal cord and other structures at risk. Now, this is a hypothesis, but very well based on simulation, and it's not my expertise, but our radiation oncologists are pretty much sure that that is true. And we started trying to start a trial, a randomized control trial showing that that is true. So in summary, they have, hope actually they have advantages over metal implants in primary as well as secondary tumors of the spine, because they have better follow-up on MRI for detection of local recurrences, which is also nowadays for at least 25% of patients with spinal mets important. You have a better post-op visualization of local complications, optimized radiation with proton and photon, and due to the fact that they have segmented depending screws, the long-term stability is provided for a couple of years. They have limitations. They cannot be contoured. The rods, the titanium screw heads still have artifacts in 3 Tesla. Handling properties are different. You got to get used to that, the different haptics. If you don't use navigation, interruptive imaging is sometimes rather difficult, and you can share that off with high bone density. And you need long constructs because the load bearing is only equivalent to 5.5 titanium alloy. Thank you very much. That's it.
Well, thank you very much. That was a great talk. And again, I think that these are very valuable implants. One quick question that I had for you. Sometimes, as you mentioned, in that kind of very active patient where you're having rod bending causing some subsidence, has there been any use of multiple rod constructs that you've seen or is on the horizon?
No, it's not, because it's difficult from an engineering point of view to do that with that type of material. So the only possibility you have to avoid that is have long constructs. So for us, it's not a big deal because most of these things we do percutaneously. So the wound is still small, which is an issue. If you do open surgery, you obviously have 3 above, 3 below, then you have a huge wound and a higher incidence of a wound breakdown if you do your adjuvant radio and chemotherapy.
And I know that we have one main vendor that we have accessible here. Are there now more companies that are kind of coming into this field? What is the kind of situation that you have with vendors out there in Munich?
Basically, there are 3. And there is a difference between those things without going into detail. The problem is if there is only one, then price is an issue. Not only with you, but also with us. Initially, the second alternative was rather not very attractive, to be honest. From an engineering point of view, they were not as good. But now for me, looking at it, it might be that there is not so much difference anymore. So there are 3 competitors now that you could use, but the anterior construct is only available from 1.
Great, thank you. Dr. Mendel, any additional comments?
Thank you, Dr. Meyer. This is a great talk. The anterior construct that you're using, is that from Icotech, the one that I see on these x-rays?
Yeah.
And are you guys putting it as a second stage surgery, or you're putting it through the back?
No, never through the back. Okay. Because we tend to do a minimum invasive for the cervical thoracic junction, but obviously you have to do it in a 1-stage procedure, an open procedure. But thoracic and even lumbar, we do percutaneous fixation, and either we do it as a one-stop shop. That means 45-degree angulation. If it's an easy procedure, we would go pedicle screws first, percutaneously, and then have the patient same position, go to the other side and do that. Or we do it staged. We do it more often staged because patients come in, we don't have an idea on their status. We don't know what type of tumor they have. And since we, in agreement with our oncologists, are very aggressive, so that they ask us more often to do surgery than we would say, yeah, it makes sense. So, but still, what you do anteriorly, we decide usually when we have, okay, it's such and such, and it has a molecular profile that gives the opportunity of therapy, so that gives a horizon of that, and then we know what to do anterior. So more often we do it staged, which is actually okay. I mean, usually it takes 5 days in between. Patient is well because he has the construct and like bracing, and he can walk around.
It seems like your philosophy is more to do these 2-stage procedures versus a separation type surgery and treat the residual tumor with radiosurgery or radiation.
This is a semantic question. It depends on how you define separation surgery. I don't know if Ilya already talked or will be talking. I mean, separation per se means just that you have a space between the tumor and the dura or the spinal cord. Whether you create that from a single posterior or from a staged anterior posterior, I think doesn't matter. It stays the way it's being separation surgery. For me, without I'm unable to prove that in a class 1 or class 2 evidence, but for me, doing a posterior percutaneous, keeping the wound very, 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 very slow, and then turning the patient around, doing a 2-inch incision, and then whatever you want to do. If you don't want to put a vertebral body replacement in there, just do your separation from there, which we do sometimes, is for me better than doing it from posteriorly, because the wound is larger and you have more blood loss, and you know the muscles are, we have spreaders in, so that I can't prove it in a sense, but our data are more like this is better that way.